Hello, everyone, and welcome back to our TSI 10-minute training sessions. I am Dr. Rob Vanbergen, and today I want to actually take a bit of a sidetrack from what would be a normal training and highlight a case that I worked on quite some time ago and the nuances that I discovered within it so that you can learn from the process as well. This one focuses quite intensely on unexpected scar tissue, and it's changed the way that I approach any client with any condition. So I think it's quite interesting to look into it. It specifically involves a diagnosis of ulcerative colitis. Now, this case was the first time that I really looked at the possibility of scar tissue forming within the body beyond what we would expect. And it opened my eyes to the importance of looking beyond the typically expected areas of scar tissue. The patient in question, who for privacy purposes we will just call patient Y, was a 41-year-old woman who had presented with a history of digestive issues dating back over 17 years. On the intake form, she had indicated that on top of the normal symptoms of ulcerative colitis, I experienced fecal incontinence issues that prevent me from being willing to leave the house and have made it challenging for me to experience a relationship. She also mentioned that she had experienced childhood trauma, but she didn't elaborate any further. Now, knowing simply from the name of the condition that this was an inflammatory condition, hence the itis in ulcerative colitis, I was sure that we could help, but her lack of detail on the symptoms did mean that I needed to look further into the condition to figure out what I would most likely be dealing with. This is one of the reasons I prefer to get that intake form prior to the session, because then I can be the most informed possible and I'm not having to guess or get extra information from a patient that may be misinformed as well. So a bit of research later, and I was left with a list of potential symptoms. I know one of them that stood out was diarrhea with blood or pus in it, because that's not the most common thing you see. Rectal bleeding as well, abdominal pain and cramping, rectal pain, needing to defecate, and an inability to defecate despite needing to. Weight loss was one, fatigue, and the one that ended up being axed off the list was fever. So it was a long list. And as symptoms of a condition, we know that if we work on the root of the issue, we can work to resolve the issue, right? And the symptoms should go away. I made sure I was armed with this list of symptoms in my notes so I could work through them with the patient, because I wasn't sure if she was over-exaggerating having every symptom, right? And that's often the case. You know, there's a lot of medical symptoms, and in some cases, for example, there's things that we could do extra, like the fever, for example, we could look to essentially immune boosting and things. So I wanted to kind of know what that would be. So at least with this in mind, I was somewhat prepared. So our first session rolls around, and my expectation is to focus on vagus nerve and the abdominal protocol, of course, after clearing the scar tissue. Now, she had not indicated any previous surgeries on the intake form, so we discussed what there may have been, and I mentioned mostly the importance of knowing these things. Now, she had thought it would be irrelevant, so she had not mentioned that a few years back she had a plate put into her ankle due to a break. So there was considerable surgery, actually. She just didn't think it was relevant. So I, of course, explained why all scar tissue is relevant, and I got her consent to start working on it. Now, during the treatment, I returned to asking questions. If there's a lot of downtime, it's a good idea to just kind of keep that conversation going, right? So I asked about the symptoms, and aside from the persistent fevers, she did say yes to every symptom. So we had eliminated one thing, and it was the one thing that made me think to myself, we might need to do something more. So it was good to know. Now, I remember the scar tissue was very, very sticky, but we'll get to that in a minute here, because I also took this opportunity to probe a little bit, as gently as I could, about the childhood trauma. I kind of asked if she'd be willing to share more about this, and she did. She opened up, revealing that she had been sexually abused from age 6 by a member of her family, and that it lasted until she was 15 when the family member got caught. So, of course, I thanked her for disclosing this. I apologized for that having happened to her, just to try and give her some comfort, and appreciated her sharing it with me. I explained to her that I felt that it could be helpful to work on the chakras. And this is actually something that we didn't end up exploring further. But now I'm a little bit more focused on that because we know that these sorts of things like the chakras, especially the sacral chakra, it's right there in the digestive system. And it honestly could have done quite a lot of good to work on that. I explained what the chakras were. Now I think I do a better job of describing them as energy systems connected to the nerves and not just talking about the chakras and what they can do in general, because I think that sciences them a little bit more for people and makes them more open to trying them. So I told her I thought it would be helpful to work on them, but she said she'd rather not do that today. Of course, we respect patients' decisions. So we continued. I kept working on the scar tissue. So I remember the scar tissue was super sticky, and after about 5 to 10 minutes of working on it and conversing with her, the stickiness had sort of melted away. So I was happy with that. I moved on to a vagus nerve session, so just a standard 3-minute vagus nerve with 7 to 12, and then I set to work on the abdominal protocol. Now, 25 minutes later, it's a long time, I was making little to no progress. We had constant failed doses and zeros indicating a communication issue, and the numbers were astronomically high, or in some cases, dismally low. So those of you who don't know, our Pinnacle device can actually display information on it, on their little screen that it has on the front here. So with this information, you can determine whether something is inflamed, degenerative, or normal based on the conductivity of the tissue. So in this case, I could see issues with inflammation, numbers actually in the low hundreds. Now, anything above 35 is inflamed, so these are considerably inflamed, but also issues with degeneration, numbers ranging from 10 to 12. Anything below 25 is considered degenerative. There's not enough conductivity moving through it. So normally, unless it's persistently low, like below 19, even though we normally say under 25, it's not really a huge concern. It's pretty minor. In fact, this is one of only a handful that I could count on 2 hands where I've ever seen numbers this low. So it was considerable and definitely noteworthy. So at this point, I could see the patient was getting uncomfortable. We've been treating for a while, repeatedly on the same spot. So I ended up switching to work on this spiral instead, which is just a sweeping motion of the spiral on the abdomen. It doesn't rely on communication or dosing and zeroing. So I just did it for about a minute, and then I moved back to another vagus nerve session. And this time I broke my normal timing. I went for 7 minutes because that was around how much time we had left. And I wrapped up the session with that. Now I got a call 2 days later from patient Y saying that she was having less pain and discomfort, but more frequency of bowel movements, which was also not good because that brings with it increased rectal bleeding and things like that. Now I told her to continue monitoring it and to let me know, but my hope was that the vagus nerve stimulation would sort of relax and reset the gut. So a week later, we had our follow-up session, and it went pretty much the same. She had seen just enough benefit to continue to this point, and still my abdominal protocol was just not really working. The numbers had improved slightly, but still they were very heavily inflamed. So some increase in, like some more of the degenerative numbers had gone up, but the inflamed numbers had gone down a little bit, but were still like in the 80s, 70s, if I recall. Now, after the session ended, this was when I started kind of a research deep dive into ulcerative colitis. And that was when I discovered that ulcerative colitis can actually cause the development of significant scar tissue and even thickening of the lining of the colon as a result. After all, ulcers are wounds, right? And then they heal up and then they rip open again. So they are creating scar tissue. So I had a new plan, which was to do a total scar clearance on the gut. Our next session, I put this plan into place. I worked over the entire gut area, clearing scar tissue, and oh my goodness, I think it took about 25 minutes alone. I've since learned not to worry so much about stickiness of scars and instead to focus on neutralization. But again, this was an older case. My treatment times were considerably longer then than they are now. I asked if she could extend the session because we were going to be running out of time, and we started the abdominal protocol. This time, the low numbers I was seeing had increased to a solid low 21, 22, so not too concerning. It's a huge improvement, actually. But most importantly, I was getting the dosing and zeroing to work. Now, I also used the scar tissue mode on our Pinnacle device for this, so that we could actually be doubling up on the clearance while taking the readings as well. Not one I often use for this, but in this case, especially with the new focus on the scar tissue, I really had to swing back to that. So the protocol only took about 15 minutes to complete, which was great. So we didn't end up having to really go over. Now, all in all, we needed 5 more sessions to get to the point where I would consider resolution to have started kicking in. But the highlight of this case is truly the importance of recognizing that scar tissue can come in all forms and for many reasons, right? Now, this is a huge part of any patient assessment that I do now, is looking for all the different scar tissues. If I hadn't gone back and done all of that extra scar work, I would have likely continued to just hit wall after wall after wall and have the patient stop booking appointments because they would have hit a wall where they weren't getting any more progress. Most importantly, we wouldn't have gotten to that point of resolution where she was able to start really working through the condition and getting it to cease and desist in the process, of course, her pain, discomfort, and all of the symptoms that she was looking to deal with. So hopefully you found this little session useful today, whether it helps you with your patients with ulcerative colitis or it just highlights the thinking process. I feel that sharing cases like this can massively help as we work toward ridding the world of pain, disease, illness. After all, we're all practitioners or aspiring practitioners, and sharing this information, even if it only helps one other patient, is going to be worth it. So thank you everyone for joining me today. I'll see you next time for another 10-minute training. You guys take care.